evening to all the respected doctors. Uh, I take this opportunity to welcome you on behalf of Hetero Healthcare. My name is Chandrakant Maurya. First of all, thank you for joining us today to discuss on Cariprazine, a novel antipsychotic treatment option in schizophrenia. As you know about Hetero Healthcare, we are largest R&D wing with having 360 solution provider, more than 25 years of excellence in multiple therapies. Currently present with more than 126 plus countries worldwide, more than 200 products across various therapies categories, such as HIV, AIDS, oncology, cardio, neurology, psychiatry. Distinction of bringing four biosimilar products to market, 36 plus state-of-art manufacturing units. And today we are having Dr. Kersi Chavda as a moderator for the session, senior consultant psychiatrist in Mumbai, past president of Bombay Psychiatry Society, consultant at PT Hinduja National Hinduja Healthcare and Sir H.N. Reliance Foundation Hospital. Has been chairperson of the task force of IPS dealing with school psychiatry and counseling. Currently advisor of IPS subcommittee dealing with mass media. Written a chapter in 4 books 2 years ago, was awarded the prestigious Dr. S.N. Lula Oration. And the eminent speaker today we are having is Dr. Avinash Sousa, consultant psychiatrist and founder trustee of D'Souza Foundation, Mumbai. Sir, I request you to please share your experience to discuss more on the subject. Over to you, sir.
Well, good evening, everyone, and it's an absolute pleasure to be here. I am going to talk today about a molecule which I have used, and I have a certain amount of clinical experience with it. And we're also going to look at some very basic facts that one needs to know before one looks at using cariprazine. So when we look at dopamine receptors, we all know that dopamine receptors play a role in the management of, schizophrenia. We have all sorts of dopamine receptors that probably work in their own way. So we have two groups of dopamine receptors that you should know. One is D1 and one is the D2 group. And the D1 group, what is very, very important is to understand that the D1 group has D1 and D5, and the D2 group has D2, D3, and D4. Now, from a clinical perspective, we all know about D2. We know a drug that we use called clozapine that has some action on D4, but we also have cariprazine that has a specific action on D3 that makes it different. Now, most of our antipsychotics work on D2. Most of the anti-Parkinsonian drugs work on D1. We don't have too many drugs working on D5, but clozapine being used in treatment-resistant schizophrenia has some action on D4, but D3 is where cariprazine acts, and that's what we're going to look at today. Yes, so when we look at dopamine functions in the brain, dopamine is very important because it controls on one level posture, movement, conditions like tics, conditions like involuntary movements. So when you have less dopamine, it leads to all these conditions. But at the same time, excessive dopamine, we know, can be associated with emotional issues. It has been implicated in schizophrenia, euphoria, hallucination, psychosis. And we basically need dopamine antagonists to work in schizophrenia. If you look at the dopamine receptors, the DRD1, dopamine 1 receptors are most abundant. It's involved with memory, it's involved with Parkinson's. The D2 receptor, if an antagonist, is very important because it blocks the addictive response. Whereas the D3 receptor, which is very important, is it has the ability to change fluctuating dopamine levels. So if dopamine levels are high, it'll bring it down. If it is low, it'll bring it up. It'll bring dopamine receptors levels to the optimum. So that's one function that the DRD3 receptor, the dopamine 3 receptor does, which is what we are concerned with. And cariprazine has some mechanism of action whereby it stabilizes dopamine. And we all know that cariprazine has a dual action. It works for depression also, it works for schizophrenia also. So stimulation at the D3 receptor is what is very important when we look at cariprazine's action. So when we look at dopamine, now this is a very simple way for us to understand. What we don't want is, we don't want less dopamine, we don't want excessive dopamine. what we want is an optimum level of dopamine. So when we mean by an optimum level, we want movement to be fine, we want hormones to be fine, we want emotion and reward to be fine. So when you look at excessive dopamine, we know we've spoken about this: psychosis, mania, etc. Multiple conditions is there. Not enough dopamine is seen not only in Parkinson's but also in depression, where we see symptoms like lack of emotion, a flat affect, anhedonia, and well, not enough dopamine can increase prolactin and cause amenorrhea in men. So dopamine receptor antagonists, we all know, can sometimes cause amenorrhea by hyperprolactinemia, which is what we monitor. It can also cause some amount of sexual issues in men. Now, we want dopamine to be maintained at an optimum level, which is very important, and that is what cariprazine does. So if you look at cariprazine, it has different mechanisms of action. It works like an atypical antipsychotic. It's a partial agonist on D2. It's a 5-HT2A antagonist. So it works on 5-HT2A and D2 as a partial agonist. It also works on 5-HT1A as a partial agonist, and that accounts for its antidepressant actions. So it has an antidepressant action along with an antipsychotic action as well. But what's new and what's different and what makes cariprazine different is it works on the D3 receptor as a partial agonist. So it helps to modulate dopamine levels in the brain. It helps to keep dopamine levels at an optimum. So that is something which I think is very vital and very important. Now, moving on from there, we also have some action of cariprazine on 5-HT2B. We have some action on the alpha adrenergic receptors. Now, this sometimes, I mean, a lot of people initially felt that would cariprazine lead to a drop in blood pressure or a rise in blood pressure, but we haven't seen that in our clinical practice. Its alpha adrenergic action has been implicated partly in a very common side effect that you see, which is akathisia, which is controllable, but that's there. Apart from that, cariprazine primarily is one of the few drugs that works on the noradrenaline system, on the dopamine system, and on the serotonergic system. So it has a triple mechanism of action. Now, this is something which is very, very important to understand before we go ahead to discuss clinical relevance and experience with cariprazine. Basically, uh, dopamine is released across the synaptic cleft, and then dopamine attaches to various dopamine receptors. And what is very, very important is that the D3 receptors have been found to show patients where you have partial agonism of the D3 receptors. They've shown to show improvements in social interaction. They've shown to show improvements as an anti-anhedonic drug. So anhedonia as a symptom improves, and it has pro-cognitive effects. D3 antagonism can also increase dopamine neurotransmission in the prefrontal cortex. And what happens is it reverses the hypodopaminergic functioning, which has been linked with negative symptoms and cognitive deficits and mood deficits in patients with schizophrenia. So it works by enhancing dopaminergic neurotransmission in the prefrontal cortex. Apart from that, what is also seen is that the increase in dopamine in the prefrontal cortex can sometimes lead to further improvements in cognition and other symptoms, because they in turn stimulate other receptors. So D3 increases dopamine, and it also regulates, in turn, it regulates glutamatergic activity. So it has a multifold mechanism. D3 has a multifold mechanism when it comes to schizophrenia, and therefore any drug that works on D3 also works well. Now, here, if you see, this is just to explain D3 antagonism and partial agonism. The whole thing is we hypothesize that this hypothetically could improve negative symptoms and cognitive impairment. So, an increase in dopamine in the prefrontal cortex regulates cortical activity and improves negative symptoms. This results in an increase in dopamine release in the prefrontal cortex, and dopamine happens to the D3 receptors. Now, very, very important areas of the brain are targeted by these D3 receptors. One is the prefrontal cortex, and the other is the ventral tegmental area. The ventral tegmental area, by virtue of its connections to the nucleus accumbens, is linked to reward mechanisms. It's also linked to positive mood. So it has mood elevating action also. Now, what happens is while these drugs work on D3 and they also work on D2, they cause some glutamate release, which modulates the glutamatergic system. We all know that the glutamate system is involved in schizophrenia, which is an entirely separate topic on its own. And therefore, cariprazine has an indirect effect via its D3 partial agonism on the glutamatergic system. So if you look at it here, if you see this slide, basically what happens is that uh, in normal individuals, the glutamate system is linked to the dopamine receptors, which is in the ventral tegmental area. What we want primarily is in patients, when you start cariprazine, what it does is it sort of regulates the glutamate system, which is dysregulated in patients with schizophrenia. And always remember, glutamate is an excitatory neurotransmitter. So you're going to see an improvement both in positive and negative symptoms if the glutamate system is regulated. So you may see a decrease in aggression, you may see a decrease in psychotic features, you may see a decrease in hallucinatory mechanisms, you may see a decrease in aggressive behavior, and regulating glutamate, in turn what happens is it makes the patient cognitively also better. Yes, so if you look at, I'll come back to the akathisia part. If you look at the pharmacokinetics of cariprazine, what's very very important is it has a half life of 2 to 4 days. Now, this is very important. Now, why is this important? It's important because its action remains. The drug doesn't go off your system. So, what's very important is if a patient misses a few doses of cariprazine, you don't have to worry. So, if he misses one day's dose, well, the drug remains, and you can restart the dose at the same level again. There's no worry per se. So that is one thing which I wanted to mention over here. So if you look at negative symptoms, now the reason I put this slide is you have different types of negative symptoms. So you have what are called primary negative symptoms, wherein the primary negative symptoms are primarily wherein you see the core negative symptoms, that is affective blunting, poor eye contact, lack of conversation, not willing to do anything. Secondary negative symptoms come primarily because of the illness itself, and it comes up because of comorbidities, multiple environmental factors. Cariprazine has a very good action primarily in primary negative symptoms, and that's where it works well. And I have seen a lot of patients improve eye contact post cariprazine. I've seen a lot of patients whose blunted affect has improved post cariprazine. We've seen a lot of patients where they've had monosyllabic conversations which have increased. Now they've started conversing more. Also, goal directed activity, which I think also comes up from the fact that it increases motility. So, avolition, there was no desire to do anything, there was a lack of will, there was anergia. All that increases. And social behavior definitely increases because of its antidepressant action. And anhedonia, which you may see in depression as well as in schizophrenia, also shows an increase. Now, the thing is, all these symptoms are very difficult to treat symptoms clinically. We use rational psychopharmacology, and here we have one drug which you can try, and it may show a response, particularly in negative symptoms. Yes, so if you look at the receptor binding profile of cariprazine, it's a partial agonist at D3, partial agonist at 2, antagonist at serotonin 2B, partial agonist at 1A, antagonist at 2A. It is a histamine antagonist. Now, this is very interesting because it's an antihistaminic H1 receptor. So, but sedation is very low. We don't see so much sedation with cariprazine. It's a 5-HT7 antagonist. 5-HT7 is concerned with mood. And there's a lot of research about 5-HT7 receptors in depression. It's a 5-HT2C antagonist, so you won't see too many gastrointestinal side effects. 5-HT2B antagonist, so you won't see too many gastrointestinal side effects. It has some affinity for alpha T1, but it's low. But it's mainly high for the dopamine and 5-HT2, 1A and 5-HT2B. So basically what it does is previous slide. Basically, what cariprazine does is when we are stuck in the treatment algorithm, it helps to blur the negative symptoms. It helps to sort of overcome the negative symptoms, which is very important. The cloudiness of the brain is what is overcome, and that is what is one action that cariprazine does. So where does cariprazine fit in the treatment algorithm of schizophrenia? This is a very, very important question. Is it a first line drug? Well, most of us will not agree. We'll say we would use cariprazine as an add on to any of our drugs that we're comfortable with, because we've been using risperidone, olanzapine, amisulpride for years, and we're very comfortable with it. So obviously we're going to use that as our first line. But cariprazine, because of its D3 action, is a good drug to add to olanzapine. It's a good drug to add to amisulpride. It's a good drug to add to aripiprazole. It's a good drug to add. So it's a good add-on drug even on day one. But of course, your primary drug, you have a primary antipsychotic with which it fits. Cariprazine takes a week or two to act. So as a first line, yes, it works. But there are some studies, but I would still say in practice, we can use it as a combination and it works much better. Where does cariprazine fit in the treatment algorithm of depression? Well, I think in depression it works much faster. In fact, 1.5 to 3 mg, it works very well in many cases of depression. And these are patients with depression that have dopaminergic symptoms. So when you have patients with purely emotional symptoms, it's more serotonergic. Purely motivational symptoms, it's more noradrenergic. And when you have patients with dopaminergic symptoms, that they say there's no joy, there's no happiness, there's no smile, there's no emotion, they feel numb. It is when many of our patients come to us and say, Doctor, I feel numb. You use cariprazine in that group of patients and you're going to see a difference. Start with 1.5 mg in the morning. You can increase to 1.5 mg morning and afternoon, or morning and night. Some patients, when you start in the night, complain of some disturbances in sleep. So I prefer to give a morning dosage. Give 3 mg, you can go up to 4.5. I've had few patients on 6 mg, but I've gone up to 4.5 in most cases. It's safe and yes, I mean effective. It works well. So you have to see week by week how it works. So if you look at its D3 action, it improves negative symptoms, depressive symptoms. Uh, it improves cognition. D2 is a partial agonist, so it improves psychotic symptoms. It causes improvement. It also, the risk of extrapyramidal symptoms is low. So you don't see EPR, frank EPR with cariprazine, though little akathisia may be seen. It has pro-cognitive action, so you don't see cognitive blunting. And most importantly, you don't see sedation. That's a very important factor with cariprazine. Next slide. Now, if you look at the adverse effects, and I'm mentioning this because uh, this is a very frank thing that we speak, you do see akathisia, if you see according to multiple measures, nausea, EPR, which includes, we don't see tremors per se, but we see more of a motor restlessness, weight gain in some patients, but less than olanzapine or risperidone, definitely. Insomnia is seen in a lot of patients, so we give it in a morning dose. We don't give it in a night dose. Very few patients talk about sedation. The good thing is low prolactin elevation, low weight gain, low QTC interval, and very few anticholinergic side effects. So it's a good drug in that sense. Now, if you look at aripiprazole and cariprazine, we're not looking at brexpiprazole because that's not yet come. But if you look at aripiprazole and cariprazine, similar akathisia effects, but the effects, if you look at cariprazine, it does have an issue with insomnia. Hyperprolactinemia doesn't cause it. Nausea and vomiting are seen with both. So the profile of aripiprazole and cariprazine is similar, but the only difference being aripiprazole can cause little more weight gain and a little more sedation compared to cariprazine. So we have to be careful in that sense. Though aripiprazole has its own specific indications where cariprazine may not fit always. Yes. So the thing is, does cariprazine fit in as a first line? Difficult to comment. We have to use it more and more, and only over time we will know. But it definitely fits as a first add-on drug, and we should use it as a first add-on drug. There are studies that talk about it as a first line, but yes, I would still put my money on a combination with another antipsychotic. Is it an antidepressant or an antipsychotic drug? It's both. Depends on what dosage you want to use it. The antipsychotic dosage is higher. You have to use it between around 3 mg to 4.5 to get the desired effect, 1.5 to 3 for an antidepressant. We need newer drugs in schizophrenia. We've not yet mastered, conquered all symptoms in schizophrenia. So we need drugs which cause less weight gain, less sedation, less EPR, modulate systems other than dopamine, works on glutamine, works on retinoids, works on multiple other systems which are implicated. So we need newer drugs in the management of schizophrenia, and cariprazine is one of the newer drugs that has come in now into our market. It's been there for some time, but it's coming now. Yes, so these are some things which I wanted to talk about, and this is something that we use every day in our practice. So when we look at these drugs, the key issue is, how do I combine? So it's a very difficult proposition, and I've just listed some of the common combinations that I've seen, I've used, I've also seen in other prescriptions. So we see cariprazine risperidone. It's a good combination, but with risperidone, it has its own side effects. Cariprazine reduces the sedation that risperidone may cause. Cariprazine, by its D3 modulation, may reduce the risk of few depressive symptoms or few OC symptoms that risperidone may cause. So it's a good combination. Cariprazine and aripiprazole is a very good combination because both modulate the dopamine system. But again, you're giving a non-sedating and a sedating drug. You're giving a drug which can cause weight gain fast and a drug that does not have so much effect on weight gain. So one has to balance the two. Cariprazine, lurasidone is not something I would put my money on. Cariprazine, olanzapine is a favorite combination that I've used. Patients with a heavy negative symptom profile, cariprazine and a low dose amisulpride below 200 mg works well, though you monitor prolactin and weight gain, of course. I have combined cariprazine with clozapine, and I found it to be very useful because clozapine sometimes doesn't resolve all symptoms, and there are a few negative symptoms where cariprazine works better. You can combine cariprazine with quetiapine if you want to give it, and insomnia is an issue. Low dose quetiapine with cariprazine is something that you can combine. You can also combine cariprazine with quetiapine if you're treating bipolar. You can use it with typical antipsychotics, but we don't use too many typical antipsychotics nowadays. But if you do use, you can combine cariprazine in that combination also. So, what are the indications I feel that cariprazine can be used? Of course, we know about depression, we know about schizophrenia, we know that it's been used there. One of the areas where I've used it is in agitated depression. It's an old diagnosis, but depression with a lot of agitation, depression with a lot of aggression, negative symptoms, it definitely works very well. Affective features with schizophrenia, it works well. I've used it as an add-on to a few patients with OCD, but we've not seen any major effects as yet in OCD. It works very well in patients with behavioral and psychological symptoms in dementia. But yes, akathisia can be a little debilitating side effect. Cariprazine, aripiprazole as a combination could work very well in borderline personality disorder, and I've been using it and we need to explore more because of its action on the ventral tegmental area, whether it can be used in patients with depression and substance use. This is very important because it might sometimes, by its action on ventral tegmental, reduce the need for reward and novelty, and it may work in some patients with substance use. I have used it to improve social interaction, eye contact in patients with autism spectrum at dose of 1.5. Of course, I've used it only in children above the age of 12 or 13, not in smaller children. Cariprazine is also a good drug to try for adolescent depression below the after the age of 13 or 14, particularly in girls when or and even in adolescents with psychotic symptoms when you don't want to give a young girl risperidone or olanzapine or amisulpride that can cause hyperprolactinemia and affect the menstrual cycle. It's a good drug. Now I've explained to you using my slides the mechanism of action of cariprazine. Now we come to clinical experience. Uh, Initially, when cariprazine was launched, we started using it at 1.5 milligrams to start with. Then after that, we went on to use it as 1.5 milligrams twice a day, 3 milligrams once a day, uh, gone up to 4.5 milligrams with courage. The most common side effect we see, because that's a very common thing that people ask me, the most common side effect that we see with cariprazine is akathisia. A lot of patients come back and say that he's become very restless post you've started him on cariprazine. One of the things I do then is reduce the dose a little. So if you started him on 3 mg or 1.5 bd, reduce the dose, the akathisia improves. You can also supplement if you want with a small dose of uh, propranolol, if you want to supplement with a small dose of promethazine, and the akathisia reduces to a large extent. Generally, if trihexyphenidyl is already present in his preparation, we may not generally add that. Yes, so these were my things that I wanted to share, and I want to give you a lot of time for questions. So if there are any questions that anyone wants to ask, share what they would like to share. And I think if there's a team that's monitoring the questions and they would like to share the questions here, I'll be more than happy to sort of answer them.
Yes, sir.
Yes, sir. There are some questions has been kept.
Yeah.
Please put in the chat box as well.
Sure, sir.
I think we will
So, sir,
ask Dr. Chavda to give his comments first, and then we can, look at questions. Yeah.
Okay, Avinash, tell me, is there any group of patients to whom you would not give the medication?
Well, I think if I've had patients who are very sensitive to akathisia as a side effect, I would probably, not give it. That's my first group. And the second group is if I feel that, uh, I have a patient where I'm unsure whether this is depression or this is psychosis, and I'm in a mix, and I don't want the pro-dopaminergic action of cariprazine to exacerbate a psychosis in those cases. So that's where I may not use it. But other than that, we've used it fairly well. But I mean, older people who, post 75, 80, I would be a little careful to give cariprazine because we don't want akathisia coming up at that age.
Pregnancy, lactation?
Not much research, and we've not used much, so we don't know. And generally, I think what happens is a patient takes it, gets pregnant, comes after 4 months, and then will deliver normally, so we'll know there was no problem. But otherwise, we don't normally, use it. Yeah.
Okay.
There's no data, so we can't really comment.
Okay. Have you ever seen something like a sensitivity, a dermatitis, a rash related to carbamazepine? I mean, to cariprazine?
I think, there are certain patients who develop skin reactions to many drugs. So if you ask me now, there are many who develop it to risperidone, there are many who develop it to olanzapine, and I think this is a patient group whose skin is overtly sensitive. So even with antibiotics or anti-malarials, they would get it. So maybe even with cariprazine, it just activates, any drug activates the immune system, and it causes this. So you may see it. I haven't really seen it in my practice.
You've also said something about addictions.
Yeah.
You're looking at it as an add-on or as a primary drug?
No, as an add-on, I would, particularly when people complain of craving, I think it's a good thing to try because it has an antidepressant as well as anti-hedonic action. So we might look and see whether it works in those patients.
I don't see any questions actually.
No, sir. Actually, there are questions like people have been asking. So the first question is from Dr. Hemant. I'll be pasting here, sir.
Yeah. Okay.
If
the patient is on antihypertensive,
Nilesh, you pose the questions to Kersi sir so that he can take it one by one.
Yeah, I can see it from here. So if there are,
Sure.
if a person is on antihypertensive medication, should we give propranolol for akathisia?
Obviously, no. Then we won't give because we don't want his BP to fall further. So we would look at risk benefit ratio and then decide. So I would then go with promethazine. I would not go with propranolol, of course.
Okay.
What is the maximum dosage for cariprazine and any positive symptom?
I have used up to 4.5. I've had 1 or 2 patients at 6 mg, but mostly 4.5.
You have seen nausea with it?
No. I have not seen, though the Journals reported as a side effect. I haven't seen, but maybe what happens is that many patients that we see generally take an antacid. You know, so they say that I had little nausea, so मैंने pan 40 ले लिया. So I think they manage the nausea on their own.
And have you seen any GI things?
No, not with cariprazine. I haven't seen any GI issues that way.
Okay, somebody is asking, can it replace aripiprazole?
No. Aripiprazole is aripiprazole. It's like asking if uh, Ranveer Singh can replace Shah Rukh Khan.
Oh,
Both are good in their own way.
in MDD, which antidepressant is suitable with cariprazine?
I gave you the whole list. You can try out, whichever you're comfortable with. I mean, I always say this in all my lectures that as psychiatrists, we are, I remember Dr. Rajesh Maniyar from Gujarat mentioning in one of his lectures that we are very delusional and stubborn about the antidepressants we use. So some people swear by escitalopram, some people swear by venlafaxine, some people swear by paroxetine. So you can combine cariprazine with any SSRI, any SNRI. I mean, it works well. So, I mean, I don't think it depends on your patient symptom profile.
Okay.
How do we avoid akathisia?
Well, I think when you take a history, it's very important if the patient has been to treatments before, ask about EPR. If you feel the patient is generally very fidgety and restless, or he's an anxious patient, I would not want to give a drug that would cause akathisia. I would avoid cariprazine in that case. But otherwise, now again, it's a very funny thing that some patients develop akathisia in the first week and it settles after some time. They just say it's much better now. I don't know whether they've got used to it or they found their own way to manage it. And it's important to also understand that when you look at akathisia, there are two components to akathisia. There's a motor component where you move, and there's also a psychological component to akathisia where they feel restless. So that the motor component is more common with uh, uh, cariprazine. So if you have a patient who has tics, he's more prone to all these kind of movement issues, then avoid cariprazine if you can.
Right.
Cariprazine and acute exacerbation of schizophrenia, is there any review?
No idea. I mean, we would still put our money on risperidone and the atypicals and serenase and other things. I mean, trying haloperidol and the other. I mean, I don't think you'd put your money on cariprazine.
Any sexual side effects?
I have not seen. Patients haven't reported. I have asked, but I mean, the only problem that arises is that when you combine it with other antidepressants, you see a lot of sexual side effects with SSRIs and the others. But we don't see so much with cariprazine because its major action is dopaminergic, which is not so harmful sexually.
What makes cariprazine superior rather than the conventional treatment option?
It's not about superior. What happens is weight gain is less. That's a big problem in our clinics. Insomnia, I mean, sleeping more, I mean, sedation is a big problem. This doesn't cause that to a large extent. And it doesn't raise prolactin. That's a good thing because aripiprazole is the one of the few antipsychotics that doesn't raise prolactin, whereas amisulpride, quetiapine, risperidone, olanzapine, all can raise prolactin. And if you have a young 16-year-old, 17-year-old girl who comes to you with psychotic symptoms and you put her on amisulpride, and let's say her menstrual cycle stops, they're going to come back to you and say, we're not going to take medication. So the simple thing is that cariprazine that way works better in that group. Aripiprazole works better in that group.
If akathisia sets in, can we stop cariprazine suddenly or does it have to be tapered off?
Well, normally I have stopped it overnight. I have told them stop the drug and I have given something for the akathisia and it works well. Sometimes I even suggest an injectable promethazine. It reduces the akathisia to a large extent and you withdraw the agent. You're giving it at 1.5 or 3 mg. It starts immediately. If it's bad, you can withdraw it at that dose. There's no problem.
Yes, sir. This much questions were only asked.
Okay, okay.
Have you ever seen anybody trying to overdose on it, use it as a suicidal
No,
thing? No.
no. I mean, the thing is, I've not really had anyone who's overdosed on cariprazine because, um, no, not at all. One of the other things that you can also give when you see akathisia to some extent is you can give clonazepam. It works well. So, but I've not seen anyone overdose on cariprazine.
Okay. I would think that is all. Is there anything else?
Yes, yes.
No, sir.
Yes, sir.
Now there
Actually,
are
all the questions. Yeah, all the
no more
questions has
questions are there.
clarified.
Okay.
Yeah. So
Sir, just one thing which was coming to my mind, because nowadays when I was discussing about this, the uses of cariprazine in the bipolar type 2 depression
Okay.
has been discussed. So how much you recommend that in your practice it should
I,
be?
I recommend it well. The only thing is because it's an antidepressant action, it can exacerbate mania. So I generally tell people to use it with a cover of a mood stabilizer.
Yeah, great, great. Thank you, sir. Thank you very much. Because that is something which was coming up. I
I
thought that
mentioned that cariprazine
yeah,
mood
you have
stabilizer
mentioned.
combination. Yeah. So it
Yeah.
works well if you use it that way. No problem.
Great.
Yeah, sir. Actually, many things has been covered from the
Yeah.
slide.
Yeah. So, Kersi sir, with your permission, can we call it a session?
Yes, I think so. I'd like to say thanks so much to Avinash for an
Yep.
extremely detailed presentation. And of course, to the company for inviting us over. Mr. Madhan, you can take.
Yeah. So, sir, thank you very much, especially to both of you, Dr. Kersi and Dr. Avinash, that when we conceptualized this program, you agreed to take out your time for this program and make it happen. Thank you very much, Kersi sir. Thank you very much, Avinash sir, for taking your time and making this program. See, today, why, in spite of after 3 years of the launch of Cariprazine, still there is a doubt in the mind of the doctors about the cariprazine, because the way this molecule was launched and promoted, probably it has not worked in all those kind of the symptoms, but still there are some people, those who are using this molecule beautifully in placing in the proper indication and proper set of the patients. And the way you all are using, I thought that this is a time that you should speak about not more about the molecule, but about the way you are using and finding suitable patients where you can enroll these kind of the molecules. So that you have presented beautifully, sir. And thank you, Kersi sir, for adding your experience, for digging out more where it can be placed and where it cannot be. See, about a molecule, it is not only the thing that where it should be used, it is also very much useful to understand that where it should not be used, when it should be stopped, and when it should be continued. So in your presentation, Avinash sir, you have addressed almost all the points, and I'm sure the audiences, all the doctors, those who are on the YouTube live streaming, they have always understood better, and they will be taking benefit out of your suggestions and your presentations as well.
Okay.
So
Thank
I
you.
thank you, both of you. I thank all my doctors, those who have attended from YouTube live stream also, for taking out the time to make this program a success. Thank you very much. With the permission of Kersi sir and Avinash sir, can we now call it a day?
Yes, yes.
Yes.
Thank you. Thank you.
Thank you. Thank you very
Have a
much.
good
So,
night.
Mr.
Bye-bye.
Srinivas, we can close this meeting. Thank you. Thank you very much.
Okay,
thank you,
sir.
sir.
Thank you so much, sir.
Thank you.
Thank you, sir.